Hello, everyone. Thank you again for joining our webinar. Just a second. So let me introduce myself. My name is Mara Ionescu, and I'm one of the members of the Young ESPGHAN committee. And today we are going to talk about the treatment of refractory gastroesophageal reflux disease. And our speaker is Dr. Michiel from Wijk. Before we start our webinar, I'm going to give you some information regarding our Young ESPGHAN committee. And I will start with our mission, which is to promote high quality research and training and organize different activities for our young members, but also to represent our interests of young members within the council and the society. And as Young ESPGHAN committee, we are conducting different educational events. And one of these is the mentorship program, which the deadline for the application has just ended. And this is a great opportunity because it's a forum for trainee members to meet and receive support from more senior full members. And this year is our third edition, and we are waiting for the new one to start. Another great event that we are organizing is during the ESPGHAN Congress, which is the Young ESPGHAN Day. And last year it was during the first day of the Congress, and we had different events. Also get an award and showcase your work, develop your skills, and build your career. And we ended with a Young ESPGHAN session with art and chocolate. And this year we are going to have also some great events too, and I'm going to present them. Also during the Congress, we have the Meet the President event. And this year, of course, we are going to do that again. And we are going to ask the president of our society different questions in order to improve our Young ESPGHAN member society. Who are we? I'm going to introduce Anne-Marie, who is also here with us today, who is the chair of our Young ESPGHAN committee, and also Vangelis, who is our secretary, Petra, who is our treasurer, Anna, Pinar, Francesca, who is our social media guru, myself, Mara Ionescu, Jose, and Giovanna, who is also with us today, Harwin, and Beno. So if you're not a member, please join us because you have many benefits. You have full subscription to our GPGN online. You have the access to different research grants and awards. You have reduced registration fees to our annual meetings. And also you have the possibility to take part to many educational events. How to do that? You have to fill the application form on our website, and you also need a CV and a letter of support from a full member in our society. Also, if you would like to know more information, you can download our app where you can find from information about our events to different guidelines. And also you can follow us on social media. You can follow us, for example, on Instagram. There are different tools that you can use. For example, you have free courses on our website, and also you have some other live events, some live courses. For example, the GI Immunology Masterclass, which is occurring as we speak. And also, for example, next month, we have the ESPGHAN Nutritional Assessment. But you can also find on the website different other courses if you'd like to join. And we would like to see you all in Helsinki this year, in 2 months, where we will have our afternoon workshop, Decoding Research, Systemic Reviews, Meta-Analysis, and Peer Review Essential, where you can gain invaluable insights into statistics and meta-analysis under the guidance of the renowned Professor Maurice Gordon. So this will take place on Wednesday during the first day of the Congress, pre-Congress actually, and you will have a chance to gain a basic understanding of statistics, systematic reviews, peer reviews. You can learn more about how to review a manuscript, and you will receive feedback and practical guidance from experts in the field. And also this year, we are going to have during Saturday a new session, navigating clinical cases for young professionals. And if you ever had any sleepless nights thinking about a patient's case, if you encountered any clinical scenarios that haven't really gone the way you plan, now we have created this perfect opportunity where you can have your case discussed with a panel of experts. So basically, we are going to launch our application, and you can submit your interesting cases, and you will get the opportunity to discuss about these cases on Saturday with a panel of experts. And don't forget to join our webinar next Monday regarding pediatric liver transplants. But also, we are going to have in April the role of machine learning and AI in pediatric GI. And after that, the role of gut-brain interaction. And of course, we are going to talk also about the role of enteral feeding in July. Without further ado, I would like to introduce Dr. Michiel van Wijk, who is going to talk about the treatment of refractory gastroesophageal reflux disease. And I would just want you to let you know that this session is going to be recorded and that you can see it again on YouTube. Thank you very much. And Michiel, you have the honor.
So can you hear me now?
Yes,
Yes.
we can hear you. Yes.
Yes.
Good afternoon to the people in Europe. I'm not sure if there's anybody outside Europe watching. I'm not sure how many you are, but we have some difficulties. This will be a webinar without video, I'm afraid, because my video is unable to be streaming live. So I'll try to do it without my face on your screen. Um, my name is Michiel van Wijk. I'm a pediatric gastroenterologist working in Amsterdam with a special interest in motility disorders and gastroesophageal reflux disease in specific. I was asked to give uh, a webinar about refractory reflux disease in children. I guess this is a topic that deserves much more time than 45 minutes, as speakers always think of their own topic. So I'll try to touch upon some points that I think are important in this perspective. First, I think it's important to realize what refractory reflux disease is, and to do that, I was trained as a by a physiologist, and I think the pathophysiology underlying reflux disease is very important in understanding which patients should be treated in which way. So I'll take you to the pathophysiology for a little bit, and also talk to you about reflux disease mimickers. I think a lot of patients that have refractory reflux disease or are labeled with refractory reflux disease, in fact, do not have reflux disease, but they have something that very much or looks a bit like reflux disease. And then we'll move to what we can do with the patients that actually do have reflux disease in terms of pharmacology and surgery. One thing I really had to cut down on is specific patient populations. Of course, neurology patients, patients with esophageal atresia are very interesting in this within this topic, but I don't have the time to go into that in detail. And I'm also not gonna elaborate much about new treatments for reflux disease that are developing in adults, um, because there's no experience with those in children yet. And I'll start with the take-home message so that you know what I am gonna try and convince you to take home. I think children with suspicion of refractory reflux disease generally do not have reflux disease. I know that this is quite a bold statement, but I'll try to show you why I think this is the case. And if they do have true refractory reflux disease, treatment options are quite limited and have side effects, if not severe side effects. So they should be chosen with caution. So what I'll start off with is some cases. I'm not gonna. I was. That's the difficulty about online presentation. I don't know how many of you are watching and listening in, so I can't really ask you what you would think about the case. So I'm just gonna go through the cases, and I'm not gonna tell you how they are, how they end until the end of the presentation, but I'll introduce them now. So we have a 14-year-old female that initially presented with heartburn and chest pain, um, and had no other symptoms of dysphagia, weight loss, or hematemesis. Um, and she was treated by the general pediatrician with 20 milligrams of omeprazole. That clearly improved symptoms for a little while, but they never really disappeared. The pediatrician increased the dose to twice daily, and she feels that the symptoms were much better after that. But 3 months after dose escalation, she reports to still have daily symptoms of heartburn and chest pain that clearly impact daily functioning. And so she was sent to me um, for further treatment. So that was the first case. We have a second case. We have a 9-month-old male who was born at 38 weeks with birth weight of around the 50th percentile, and had feeding-related symptoms of excessive crying and regurgitation since the age of 2 months. He was fed breast milk since birth, and when he was a few months old, he was introduced with solids, performed according to the guidelines in the Netherlands, and did not improve. That did not improve the clinical symptoms. By the GP and the general pediatrician, his mother was put on a cow milk's free diet because they thought it must be cow milk's allergy. Breast milk was expressed and thickened. There was postural advice given according to all the guidelines there are. And parents even took him to the osteopath, but nothing helped. He was admitted because the parents were exhausted, and after a few days he was sent home, and nothing was really changed in the clinical therapy. His weight was stable, but not for the first few months after birth, but after his 4th month in life, he remained stable around the 30th percentile of weight for age. And then parents were advised by their neighbors to try esomeprazole, as their child had that when he was young, and they actually bought it at the local drugstore without telling the pediatrician. Opened the capsules and added the contents to the expressed breast milk, and parents now come to your office and report that the symptoms are gone since they do this. Third case is a 4-year-old female with a history of infant regurgitation. She was diagnosed with night terror by the pediatrician, but parents are sure it's related to reflux because she smells acidic in the morning. I'm just going to show you a video of the girl sleeping and what's happening. Oops, sorry. This is the next one. Let's see why this is not working. Here we go. And I'm afraid you don't hear the sound, but you can see at least that she wakes up all of a sudden in panic. I was very impressed by this video because it is recorded by someone who's living girl B. So she must be very used to this happening, and the one who's recording, because I, as a parent, wouldn't be able to just stand there and record this video. Anyway, she wakes up once or multiple times a night with this types of terror, and parents think it's reflux disease. Then there's this case, the fourth case. It's a 5-year-old female with a history of infant regurgitation and feeding problems, but was this resolved at before the age of 1 year, and she grew well afterwards, but developed basically a head that she kept, like you can see here in the picture. And the pediatrician thought this must be Sandefur syndrome. And she put her on 20 milligrams of omeprazole and ranitidine, but this didn't change anything in her head positioning. And I do have some videos of her too. You can see her standing there. That's one. And then we have another one. This is during a meal. So this is a Dutch song she's trying to sing. So although she's keeping her head like that, she doesn't seem to be in much distress. That was the first case, and then there's a fifth and last case. This is a 3-year-old male with no medical history. He started regurgitation at the age of 2, not too long ago, and it increased over time. He was put on PPI by the general pediatrician, and because it didn't help at all, he was referred with the question whether he should have a fundoplication. And this is him in our hospital. And this is what happened when I was trying to do a physical exam. It clearly shows what his parents are worried about. He's regurgitating, and this didn't improve at all after giving the PPI. Okay, so now you've been introduced to some of my patients. Let's look at definitions. What is refractory GERD? It is reflux disease that is refractory to first line or second line of therapy, and that can include feed thickening, postural advice on feed volume in infants, lifestyle changes in older children, but also acid suppression with PPI most of the times, or other acid suppressive medication. For the sake of this presentation, I'm going to use the acid suppression as a part of the definition of refractory reflux disease. So we're not going to talk about when to start feed thickeners, when to start cow milk-free diet in infants, or when to start the first trial of PPI in older children. But before we can say something about refractory reflux disease, we should really have a good idea about reflux disease. And I know this might seem semantic because it's just words that are on the slide, but this is the definition that was given in the last ESPGHAN and NESPGHAN guideline, when reflux leads to troublesome symptoms that affect daily functioning and or complication. And I'd like you to focus on some of the words that are in this definition, and the fact that reflux needs to lead to the symptoms means that there has to be a relation between reflux and symptoms. If a patient has a lot of reflux and a lot of symptoms, that doesn't necessarily mean that they have reflux disease. And this is important, and I'll show you later why, but it's important to keep in mind for now. So if we want to know what reflux disease is, and reflux disease is defined as reflux, then we also have to know what reflux is. And this is an adaptation of the definition that is given in the guidelines again, with the passive movement of gastric contents into the esophagus with or without regurgitation and vomiting. There's a few things in this definition that are important. First of all, the passive movement, if it's an active movement of gastric contents into the esophagus, it's likely either rumination or vomiting rather than reflux. And of course, this is a bit, the addition at the end with or without regurgitation and vomiting is a bit strange, because you can also say that it's with or without headache. And it really is the flow of gastric contents into the esophagus. And some children, and that's probably what the definition is meant to say, do not have symptoms of that. Okay, having clear what we mean with reflux disease and reflux, let's move to the pathophysiology of reflux disease. First of all, you can see the anatomy here of the esophagogastric junction. So here's the stomach, here's the internal lower esophageal sphincter, internal sphincter, and then you have a sort of an external sphincter, which is basically the crust of the diaphragm. And these sphincters together form the esophagogastric junction and the barrier for reflux disease. The barrier for reflux coming up from the stomach to the esophagus. But they also allow for belching. And I think it's important to realize that that's probably the function of these this sphincter complex, because many of you probably heard colleagues saying to parents of babies that the development of the sphincter was not complete when they were an infant, and that's why they regurgitate too much. But the fact is that these sphincter complexes are closed if they are not working. So if the sphincter is not working, you have achalasia or something like achalasia. You don't get reflux. In fact, you can't belch. It was also proven that the sphincter complex is fully functioning at the age of 28 weeks after gestation. It might be something to tell the patients, but remember that it's not the entire truth. What happens then when you do have reflux? There is a transient lower esophageal sphincter relaxation, or TLESR, preceding most of the reflux events in infants, children, older children, and adults. This is a simultaneous relaxation of the internal and external lower esophageal sphincter, so both of them simultaneously relax, and it's neurologically regulated through the brainstem. I'll show you how we know that this happens. This is an old-fashioned low-resolution manometry catheter that is inserted in the esophagus here, and you can see this generates a swallow, or shows a swallow on the screen, which is followed by relaxation of the lower esophageal sphincter here in green, and peristalsis in the esophageal body. I'm not going to go much into detail in manometry, but this is a normal swallow that you see with a normal relaxation that is swallow related. You can also have a relaxation of the lower esophageal sphincter here that is not preceded by a swallow and is in fact deeper, more relaxing than the one that you see here. And it is also longer in time. And this is what we call a transient lower esophageal sphincter relaxation. Now I can show you it in more modern ways of high resolution manometry. And what you see here is a high pressure zone at the top and a high pressure zone at the bottom. And you see that here, the high pressure zone, the light blue becomes dark blue, meaning that the pressure fades away and that you have a relaxation of your lower esophageal sphincter. And at the meantime, you see at the impedance trace in white that there is a drop in impedance that goes in the aboral direction, showing that there is reflux coming up. So this is a transient lower esophageal sphincter relaxation, and you see that at the time that there is such a relaxation, there is reflux, um, showing that this mechanism occurs. And we know this from adult data. There's a lot of adult data about this, but there's also pediatric data. And this is a study, quite old study already with old-fashioned manometry, where healthy premature infants that had a feeding tube were intubated with a manometry catheter, and they show that most of the reflux episodes that these prematures had were related to transient lower esophageal sphincter relaxation, and only some of them were related to swallow or low basal lower esophageal sphincter pressure. In children with reflux disease, it was exactly the same. Transient lower esophageal sphincter relaxations are the main mechanism underlying reflux events. So whether you do have reflux or reflux disease, physiological reflux or reflux disease, the transient lower esophageal sphincter relaxation is the main mechanism underlying your reflux events. Now, how do you get to transient lower esophageal sphincter relaxation? From adults, we know that if you distend the proximal stomach with the balloon in this case, you get more transient lower esophageal sphincter relaxations as compared to putting the balloon in the stomach of the patient and telling the patient that you are distending, but you are in fact not distending the balloon, and that shows a huge difference between the number of TLESRs in the 15 minutes after the balloon distension. How does that work? Gastric distension triggers activation of cardiac mechanoreceptors. So here's the proximal stomach. There's cardiac mechanoreceptors here, and you get an vagal activation that goes into the brainstem, comes out of the brainstem again, and tells the lower esophageal sphincter here to relax. It also activates the nucleus ambiguus. It then goes to the respiratory center and the nucleus phrenicis that relaxes the crest of the diaphragm at the same time. Now, this is important to realize, for example, because of one of the GERD mimickers I'll talk about is a brain tumor. And if a brain tumor, we always think that brain tumors cause vomiting and regurgitation because of high pressure in the liquor, but it can also be a tumor that actually presses on this area of the brainstem. You get much more subtle symptoms that really can look like reflux disease. Okay, back to the TLESRs that are underlying all these reflux events. Strange enough, first it was thought that people with reflux disease would have more TLESR as compared to patients with physiological reflux, but that's not the case. It is clear that if you have a TLESR and you have reflux disease, it's more likely that your TLESR will be accompanied with liquid and acidic reflux, while other people that do not have reflux disease will have TLESR with air coming out, so they belch. So it seems to be that the EGJ, the esophagogastric junction, is able to detect what is sitting in the proximal stomach and should normally only open when there is air that needs to come out. And if there is something with if there's something wrong with that mechanism and we don't know what it is, then it opens at other times when liquid comes up. Another factor we need to address during about the pathophysiology is the esophageal body motility. I said I wasn't going to talk much about manometry, but here's one other slide about manometry. Here you can see a normal swallow. You see the high pressure zone of the upper esophageal sphincter, the high pressure zone of the lower esophageal sphincter. You see a swallow here. UES opens. Um, you see a peristaltic wave going through from the proximal esophagus here to the distal esophagus here. And you see at the same time that the lower esophageal sphincter opens up to let the bolus through. So this is a normal swallow. And if you know that reflux normally triggers either a swallow or secondary peristalsis, which looks exactly like this, and you can imagine that if you have a reflux episode that comes up and you have this swallow in the middle um, that is weak and is not as well pushing the bolus back down, that the reflux and the acid primarily will um, remain in the esophagus much longer than it would when you have an effective swallow like you have here. And this is especially the case in patients that have a manometry like this, where there is in fact no peristalsis. And if you have no peristalsis and the esophagus comes in, or sorry, the reflux comes in to the esophagus, and you're lying flat in bed, the reflux is not going to go back down until you stand up. So these are factors that are very important in terms of acid exposure time of the esophagus when you have reflux. Now, there's one other thing that I'd like to just quickly um, mention. Many people think about reflux disease and gastric emptying as a um, quite logical causal relation. So if you have delayed gastric emptying, you must have more reflux disease. It must be easier to have more reflux disease, because if you have more gastric contents, you will have more gastric distension, and you will have more transient lower esophageal sphincter relaxations, hence more reflux. However, what we do know is that it does not lead to more pathological reflux, not more acid reflux. It leads to more non-acid reflux with more proximal extent, meaning that it comes up more proximally. But it seems that the mixing of the food that leads to more buffering of the acid in patients that have delayed gastric emptying, and therefore it doesn't necessarily lead to more reflux disease in terms of acid. A few words on specific pathophysiology on infants. I'm not sure how about the public, but if you are all young ESPGHANs, I'm not sure if you all remember Austin Powers, but this was a television series that was broadcasted years ago, and there was a guy on the left that was called Mini-Me. Mini-Me was the smaller version of this guy here. And I'm showing these two because pathophysiology of infants in terms of reflux diseases, volume becomes an issue. In infants, we generally give 150 mLs per kilo, which means that you have about 750 mLs of milk per day. And if you recalculate that for an adult, you come down. It will come down to 12 liters of milk per day, and I'm not sure if any of you can handle 12 liters of milk without regurgitating. So we are physiologically overfeeding our infants, and we have to, because they have to grow. But it means that they will have continuous distension of the proximal stomach, continuous triggering of transient lower esophageal sphincter relaxations, and continuous reflux disease. So reflux, as you all know, is a physiological mechanism, but it's very physiological in infants that are uh, uh, being fed until they can't feed anymore. One of the key things about this slide is that I still get patients in my tertiary outpatient clinic where the only thing I have to do is tell the parents to reduce the feed because they are overfeeding. They think that when a baby cries that um, they are hungry, they give him or her more food, more milk, and because they have a sucking reflex, they have to drink it. They feed themselves more, and they get more distension, more reflux. They start to cry more, and then we have a vicious circle that makes them regurgitate a lot. Another interesting fact about infants is the pH of the stomach. If you look at patients that are 4-hourly, 3-hourly, or 2-hourly fed, this is the pH that we see in the stomach of these children. You see every time you give a feed, milk in this case, um, uh, you see that the pH goes up to around 7. This happens in all children, whether they are in the NICU with a 2-hourly feed or whether they are at home with a 4-hourly feed. But it also means that um, to have acid in your stomach, um, this only happens in the 2 hours just before the next meal in a 4-hourly fed baby. It only happens for a very short period of time in the 3-hourly fed, and it doesn't happen at all in the NICU. So patients in the NICU generally do not have acid in the stomach. Remember that. If you go to your NICU now, and if I do it too, there's a fraction of the patients on PPI. It doesn't make any sense if they have continuous feed or 2-hourly feed or 1-hourly feed. These babies do not have acid in the stomach, let alone that they can have acid coming up. And this is what we see in older children too. If you give a feed, stomach pH, older infants, this is stomach pH goes up when you feed, and you see that a feed does trigger transient lower esophageal sphincter relaxations here, but all the blue bars are not associated with acid reflux. So they are either associated with non-acid reflux or they are associated with air. And only after 80, 100 minutes, um, then you start to see some acid reflux associated with transient lower esophageal sphincter relaxations, but the number of TLSRs have already reduced to the normal baseline at that time. So um, a feed actually in infants with milk prevents from acid reflux. And then there's posture in infants. Of course, we lay babies down. And if you put the baby in the left lateral position or right lateral position, it makes a huge difference on pathophysiology, physiology in infants. This is the gastric emptying time in the right lateral position compared to the left lateral position. And you can see that it doubles from right to left or reduces by half if you put the patient from left to right. Now, there is no domperidone, erythromycin, augmentin, whatever medicine that does this. So this is something that you have to really realize if you have a patient that is regurgitating a lot. You think it might be related to gastric emptying problems. Check how the patient is being held after a meal. And it does also do a lot on transient lower esophageal sphincter relaxation triggering. If you see here in the left lateral position, there is much less TLSRs. Now remember, in the left lateral position, we had a much slower gastric emptying. So we have a slower gastric emptying with less TLSR. And you can see this is the proof that in infants it's not one-on-one causal relation, that that the slower gastric emptying does cause more reflux. And this is the numbers to prove it, because it's not just the TLESRs, but it's also the reflux episodes that are much less in the left lateral position. So if you have a patient that you think does not have gastric emptying problems, but reflux problems, then the left lateral position might be better, while gastric emptying might benefit from right lateral positioning. And there's another interesting issue if you look at the difference between healthy control infants and reflux disease babies. You see that in the right lateral position, reflux disease babies here trigger much more transient lower esophageal sphincter relaxations, while you don't see that difference in healthy controls. So again, there is something with that selection of when to trigger transient lower esophageal sphincter relaxations that makes patients having reflux disease rather than being healthy. Okay, so done with the pathophysiology, but I'd like to ask you to keep in mind what we've just gone through when we think about therapy. We have a refractory patient. Now what? The first, and I think foremost important advice I can give you is take a thorough history. Invest time to listen to parents, especially in the infants that have already heard multiple doctors say that there's nothing wrong with them, because the parents don't believe there's nothing wrong. You have to listen to them. And this is not just to calm down parents, it's also to be sure that there is not um, clues that this could be a reflux disease mimicker. And what am I talking about when I talk about reflux disease mimickers? There are many, and I've put them in some groups for you. In the infants, we have anatomical problems: duodenal web, annular pancreas, congenital stenosis of the esophagus, malrotation. We just had a patient with microgastria, which is very, very, very rare, but all of these cause much more reflux or reflux-like symptoms, and should be ruled out in this patient group. But we also have functional diseases, or DGBIs as we call them now, like reflux hypersensitivity or esophageal hypersensitivity. I prefer the latter because the reflux is not hypersensitive, the esophagus is hypersensitive. We have functional heartburn, we have rumination syndrome, we have aerophagia. You might wonder, why would that cause reflux symptoms? If you swallow a lot of air, you get distension of the stomach, you get more possible reflux because the lower esophageal sphincter opens up, and you also get a lot of belching, which is often related to reflux as well. Cyclic vomiting syndrome, it's one of the ones that I'm not really sure whether it should be in there, because it's normally very classic in terms of history, so you should be able to rule that out. But functional dyspepsia, functional nausea and vomiting, especially in the children that are not verbally able to express their symptoms yet, can also cause a clinical picture that looks like reflux disease. There's always the big elephant of eosinophilic esophagitis in the room. And in fact, I am one of the believers that patients with eosinophilic esophagitis always have some form of dysphagia. Of course, you can't ask young children if they have dysphagia, but they will show more than just regurgitation, in my opinion. And there's normal physiology that can look a lot like reflux disease. Infant rumination shouldn't be there. That should be infant regurgitation syndrome. Infant rumination should be up at the DGBI. And then neurological, as I said before, you can have brain tumors, and especially the slow slowly proliferating gliomas, the astrocytomas in early infancy may be may look very much like reflux disease. I myself had, I think, 2 cases that I missed for a long period of time before we did the MRI, and we found the tumor. But if you still think it might be reflux disease, what do you do? Well, this is what I do. Um, and this is an algorithm that I proposed together with Usha Krishnan. Um, uh, but it's not, this is not the truth. It's just a way of working with difficult patients. If you have symptoms that are thought to be reflux related and not responded to standard treatment for reflux disease, I think it's important to think about dysphagia. First of all, because if a patient does show signs of dysphagia, for example, an infant with feeding problems and regurgitation, or an older child with slow eating and um, heartburn or chest pain or whatever the patient refers to, um, then I think I would go to endoscopy quite quickly to do biopsies to rule out EOE, unless with your history you have reasons to believe that there might be something like achalasia in the older children, for which you would want to do an esophagogram first, maybe, and or even do a high resolution manometry. If you have the endoscopy and you do find EOE, of course, or something else, you have to treat it based on what you find, but it's not reflux disease. Of course, you can also find um, uh, reflux esophagitis, and then you get here to macroscopic and or histologic abnormalities. If you do have macroscopic abnormalities, you have reflux disease. You have, unless there is eosinophils in the histology, because then it's eosinophilic esophagitis. But the diagnosis of reflux esophagitis is based primarily on macroscopic findings. Many pathologists will report on biopsies that you send in with microscopic esophagitis or inflammation that may be reflux related or something like that. If you do not see macroscopic abnormalities, this should not be considered as reflux esophagitis. So if you have normal macroscopy and um, no true histologic abnormalities, um, then you go to pH impedance testing or pH testing if you do not have impedance available. Unless you are an infant, and I took the age range quite broad from 0 to 18 months. If you are in this age range and you have a normal growth um, and development, and you don't have alarm symptoms, um, and you can consider this to be normal physiology without any further testing. However, if you do have growth failure, or you are not an infant, you have to do the endoscopy. So now we're here. You have reflux testing off therapy. If a patient comes in for the first time and you don't have an objective diagnosis of reflux disease yet, you always have to do the testing off therapy. So only if you would have macroscopic esophagitis before, or you would have had a pH impedance test that already has shown that you have reflux disease, then there might be a reason for on therapy testing, but normally you do the diagnosis on off testing. If you have abnormal acid exposure, you have non-erosive reflux disease, because if you would have erosive reflux disease, you would be here with your macroscopic abnormalities. If you don't have abnormal acid exposure, but you do have a positive symptom association, so you have a normal amount of acid, but you show that every time that you have a symptom, it was preceded by acid or non-acid reflux. You have reflux hypersensitivity. Um, Positive symptom association is negative, then you have functional heartburn or another reflux disease mimicker. So this is basically the diagnostic approach in these children that have the suspicion of refractory GERD. Let's go to our patient, our first patient. She was 14-year-old and presented with heartburn, chest pain, and didn't respond fully to omeprazole 20 milligrams and then double dose. She didn't fully respond to either. We took her off the medicine. She had normal macroscopy. On endoscopy, she had biopsies showing microscopic signs of reflux related inflammation, but no eosinophils. So just like I said just before, this is a normal endoscopy, even though there's microscopic esophagitis. And we put her on pH. We did her pH impedance test that revealed a normal acid exposure time, 38 reflux episodes, which is not much, with a clear positive symptom association. So all symptoms were preceded by um, reflux. So this is hypersensitive esophagus or hypersensitive reflux hypersensitivity. Now, for the sake of this talk, because this is what always happens, if this 14-year-old comes in, it is hardly ever truly refractory reflux disease. Most of the times it's something else. Let's assume now that she had non-erosive, normal endoscopy, but acid reflux disease. She had a high acid exposure time on the pH impedance and a positive association between symptoms and acid reflux events. And see what we would have done then. She was not responding to PPI or double dose PPI, so how could it be that she's still having symptoms? Mind you, the testing was done off PPI, so it's not that we already have proved that the acid is still the cause of the symptoms. Because if you would put her back on PPI and do the test again, that would be necessary to prove that. Well, I started preparing this talk, and this came out this week. This is an adult group of experts that tells exactly what you should do in adults in patients with refractory reflux. And as you can see, what I said before as well, they don't call it a refractory reflux disease, they call it refractory reflux-like symptoms. So also saying that many of these patients will not have true reflux disease. But you can use this for adolescents and also for adults to see what options you have when you have a patient with these symptoms. However, we do have pediatric patients, and I think there are a few things that are different. Especially, for example, in this 14-year-old, but not only the 14-year-old, but also the younger children, you have to be sure about the compliance. Teenagers, of course, don't take their medicine. And if they do, they don't do it as you said. And in younger children, it's sometimes very hard to get the medicine in. And parents start to work around it, and they put it in all kinds of stuff, but they don't prepare it, for example, the way it should. So like in Nexium or esomeprazole, it after you put water in it, you have to stir the Nexium and then wait for 10 minutes. Hardly anybody does this, but it makes It's quite necessary for the pharmacological delivery of the esomeprazole to the small bowel. So assess compliance not only in terms of do you take the medicine, but also how do you take the medicine. If you are quite convinced that the patient is taking the medicine and does not respond to PPI, I would suggest to assess the CYP2C19 metabolizer status and adjust the PPI dose accordingly. There is this paper by Dr. Lima who has described this in very much detail for adults. There's no such paper for pediatrics yet, but if you are an ultra rapid metabolizer, you need higher doses of PPI, while when you are a poor metabolizer, you probably can reduce the dose. I'm not saying you should put each patient through this test because it's not necessary for normal patients, but only for the refractory patients I do it. And then make sure lifestyle advices are implemented. Of course, in your obese patients, they have to reduce weight, and they come back and they say, "Yeah, well, I still have the symptoms, but they still haven't lost weight." And I know how difficult it is, but it is something that we need to keep in mind that many non-pharmacological, non-surgical options are present to be able to reduce the symptoms of reflux. If that is all done, then do a pH impedance test again, but then on optimal PPI therapy. And then this will give you three options. You have either abnormal acid exposure on PPI therapy. That means there's either very, very bad compliance, or there is something extremely rare in children like Zollinger-Ellison, or also extremely rare in children that the dose is still too low, or people are not responding to PPI for some other reason, not responding in terms of reducing the acid in the stomach. The second option you can get from a pH impedance test on therapy is that you have normal acid exposure and a positive symptom association. So the acidity is well treated, but the patient still has symptoms that are related to reflux. This is non-acid reflux, and the bolus coming up is actually responsible for the symptoms. Now, this might have been the case before you even started PPI therapy. So remember that these patients already had a previous test which showed that they had acid, too much acid in their esophagus. So they do have reflux disease, but they do not have acid as the cause of their symptoms. And then there's normal acid exposure and negative symptom association. Oh, hold on just 1 second about the previous one. This can also be a hypersensitive esophagus on top of reflux. While you have treated the reflux disease, the acid of the reflux disease, you still have a response of the non-acid reflux bolus that causes symptoms. And then the last group is the patients with normal acid exposure and a negative symptom association on PPI therapy. And these have some form of DGBI on top of reflux disease or another disease. Now, how are we going to treat these three groups? First of all, the third group that I showed you with the DGBI or other diseases I'm not going to go into, they should be treated according to their own guidelines. If you have a patient with abnormal acid exposure on optimal PPI therapy, as I said, think about compliance, talk about compliance. I actually sometimes admit a patient and give them the PPI, have the nurse give them the PPI, and then do a pH test, pH impedance test to see whether they truly do not respond to PPI therapy, because I just don't believe it if they don't. But if they really have acid exposure on PPI therapy, you can add H2 receptor antagonists, you can add anti-SIDA, as you all know, and I think you should consider baclofen. Baclofen is a medicine that you are probably also aware of, that's used in neurology um, quite a lot for spasm, but it's also shown, sorry, it's also shown to reduce the number of transient lower esophageal sphincter relaxation as compared to placebo. This is in children. There is larger data on adults, which shows the same. And in addition to what I show here, it also speeds up gastric emptying. So it has two effects, and one of them is reducing the number of transient lower esophageal sphincter relaxations and acid reflux events. However, baclofen is not an easy medicine. It has side effects. It can give muscle weakness. It can give severe tiredness. It can reduce your respiration drive. So it should be taken with caution. This is a retrospective study showing that if you have 53 patients that are on baclofen, about 22 of them will have a long-term response. So that's not bad for a refractory patient. Are there surgical options? Yes, there are, but I am very reluctant to go to surgery with patients with reflux disease. First of all, um, uh, because I think many of them do not need additional therapy. But having said that, the patient who do should be only sent to a surgeon with a positive symptom association probability score or symptom association on impedance. This is why, if you look at the percentage of patients with success with positive symptom associations, the SI, SAP are both symptom associations. So if you have SI or SAP, about 50%, uh, yeah, 50% um, with a positive 50%. How's this? um, yeah, so if you have a positive SI or SAP, there's still 57% failure, and there's no failures if you have a positive SAP. Um, not really sure how this works. Anyway, I think this is the most important one, the positive SAP. So if you have a positive SAP, there is clearly a difference that there is only successful patients. Oh, this is probably the number of patients. I'm sorry, this graph is not very clear, but it does show that if you have a positive SAP on impedance testing, the chances of having a successful anti-reflux procedure are much higher. Also, I think it's very important to have a high-resolution manometry performed in addition to endoscopy and impedance testing, because first of all, you can check whether there are no major motility disorders like achalasia. There was this one study where lots of people with fundoplication were reviewed, and they showed that actually quite a percentage had achalasia in adults. I'm not saying that you'll find many achalasia patients, but I'm saying that that would be a very wrong choice to give a fundoplication in these patients. But also to think about the chances of having side effects after the procedure. Because if this is the normal swallow, and I already showed you this, you can imagine that if you have, you put a extra high pressure zone here, what you do when you give a fundoplication, you'll increase the resistance to flow in the esophagus, which means that you'll need more force to have a swallow go into the stomach. If you have something like this, or even this, um, in fact, you will get, you're much more likely to get dysphagia or problems clearing your esophagus from reflux when you have when you do a fundoplication in these patients, where the resistance to flow will only be higher because of the fundoplication, without any peristalsis in the esophagus. Consider high resolution impedance manometry. Now, in adults, there is data that this can predict whether patients will get dysphagia, and there is also a small study in children where there are 10 patients, 6 of them did not have dysphagia, and 40% had dysphagia. So that's important to realize as well. So a high percentage of patients get postoperative dysphagia, but they could all be predicted with impedance manometry. I will not go into the details of how to calculate the dysphagia risk index, but I'm happy to give another webinar on impedance manometry if people would like that. And also consider growth. This is not something that is scientifically proven, but you can imagine that if you have a small esophagus, small diameter esophagus, and you wrap your fundus around it, this will create scar tissue around it, and you will lose the ability to grow your esophagus in diameter. And by not being able to do so, um, you will have some patients that grow older and get post-operative dysphagia later in life. Again, this is not based on literature, but I see these patients that come in 8, 9, 10 years after fundoplication, and then all of a sudden have problems swallowing. And they are very, very hard to treat. So this is something you have to consider when you give your young patient a fundoplication. Now, in the other group, the group that has normal acid exposure, an abnormal number of reflux events, and a positive symptom association. These are patients that have reflux that is not necessarily harmful for their esophagus. They do have symptoms from it, but it's not going to cause esophagitis. It's not going to cause Barrett's esophagus. It's not going to cause cancer. So in these cases, before you do something like baclofen or surgery, I think it's very important to discuss with the patient how much impact the symptoms have and whether they should be the reason to do interventions with serious side effects. Why am I saying this? Well, this is a list of side effects that was reported in literature on fundoplication, and they go from mild dysphagia to death, with everything you can imagine in between. So I think it is important that you realize that fundoplication is not a very easy surgery with only few side effects. Long-term side effects I already discussed. I said I'm probably not the only one seeing those children long after fundoplication, and I sometimes do manometry. I do endoflip on them, and then I'm in doubt. Then I treat them with balloon dilation sometimes, but it rarely really helps. So these patients will have problems for the rest of their lives probably. So let's go back to the cases and see how they turned out with everything we know now. The 14-year-old we already knew there was esophageal hypersensitivity. The 9-month-old male with the feeding-related symptoms of excessive crying or regurgitation, we put him on. We discussed with the parents. We saying that it would probably be normal physiology, but we could do pH impedance test to prove that the esomeprazole was not necessary. We did. We did an endoscopy of therapy, both, and they were both normal. And then we kept the patient off medication, and he grew well afterwards and was relieved of his symptoms at the age of, I believe, 1 year. This girl, in fact, had severe reflux disease. She had esophagitis on grade D esophagitis on endoscopy, but she was put on PPI therapy, and that healed the esophagitis. But we kept her on PPI therapy up until now. She's about 10 years old now. This 5-year-old is now 9-year-old, I believe, and she also had severe reflux disease, severe erosive reflux disease that we found on endoscopy. We took her off. We did the CYP2C19 metabolizing, but she was normally metabolizing the PPI. So we stopped the H2 receptor antagonist and started baclofen. And then she improved slowly, especially the movements of her head took a long time. But in the meantime, we had seen that her esophagus had normalized and the pH impedance test was normal on therapy. And this boy, of course, had rumination syndrome, which I diagnosed on the spot without any further testing. So, my take-home message again, children with suspicion of refractory GERD generally do not have reflux disease. And if they do, treatment options are limited and have side effects, so choose them with caution. And before I take your questions, I'd like to advertise something as well, like the host did. We host the third World Congress on pediatric neurogastroenterology and motility in September in Amsterdam, which will be a 3-day event with a lot of reflux, but also other neurogastroenterology and motility. And if you are really interested in motility testing, come join us for the Motility Winter School in November, which will be held in Amsterdam too, and should soon be advertised on the ESPGHAN website. And with that, I thank you for your attention and happy to answer any questions.
Thank you so much for this great presentation. And I just want to ask the participants, if you have any question, just please write it in the chat box. So Giovanna, if you would like to start with
Yes, thank you, Michiel, for the fantastic presentation. There is already one question in the box. They are asking, would it be okay to perform pH metry only without endoscopy?
That's a good question. I must admit I do that quite often, but according to guidelines and according to guidelines that are coming, it will be recommended to do the endoscopy first. However, as I told you before, I believe that eosinophilic esophagitis is something that, if you take the time to talk to your patient, is something that you can normally get the feeling that there is something more than just regurgitation. And in these cases, I would definitely do an endoscopy first. But in the others, I'm not so sure if we need to put all our patients in an endoscopy. But it's something that we need to do research on to prove which patients can be left out with endoscopy.
There is another question that's very important, this question, and I think you already mentioned that. Do you recommend manometry before doing a surgical intervention?
Definitely. Don't ever do a surgical intervention without manometry. I would recommend the full workup. I would do an endoscopy. I would do a pH impedance test, and I would do a manometry. Just because I knew these type of questions would be coming, I checked in our hospital, and since I work here, and I haven't been a great fan of fan application since I started working, but we only did 6 fundoplication in the last 20 years in neurologically normal children. Just to give you an idea about how often we really get to a fundoplication in children. But if I think about it, I do a manometry to make sure that there's nothing else going on, and to make sure that these children do not have absent contractility, as we call it, which is really an esophagus that is not pushing the bolus to the stomach. And if you then create the high pressure zone between the esophagus and the stomach, it will probably end up with a lot of problems afterwards.
Disaster. Yeah. Michiel, in the meantime, they ask more questions. I mean, can I ask a question, give a comment? I think the difficulty regarding assessing a manometry before considering a surgical intervention is the if there is a secondary motility disorder, because I mean, GERD can cause, for example, ineffective esophageal motility, or I don't know, maybe even an absent motility. And so the question is, in children, they are really resistant to PPI because maybe you prove it, obviously. So I mean, how do you distinguish a primary disorder to secondary disorder? Do you repeat manometry along the time, and do you see if the disorder is reversible, because maybe it's been caused by the reflux and you are trying to treat it, but if it's resistant, maybe they will not reverse? I don't know. I wonder this.
Yeah.
This is a very few cases, but
No, I understand, and I think it's an important question. We don't have pediatric data on this, but we do know from adults that absent contractility is not caused by reflux. If you truly have no contractility whatsoever, then you have to think about other diseases. You have to think about scleroderma, stuff like that. But if you have hypocontractile esophagus, so your esophagus is not pushing hard enough, this is not a very hard reason not to do a fundoplication, but it's something that you have to consider and take into consideration when you talk to your patients, that it might be that they have dysphagia afterwards. And indeed, it might also be that the fundoplication will actually improve that less severe, less strong pushing of the esophagus to the stomach.
yeah. We have more questions. They are asking, how do you treat non-erosive GERD, reflux present on impedance but not acidic, no symptom association? So,
I wouldn't. It's an easy question. If you, I mean, you and I probably have reflux while we're sitting here, and if that's non-erosive, and it's present but it's not acidic, and there is no symptom association, there's no reason to treat it. It's just normal physiology.
because I think the question is a reflux present on impedance. Maybe they say that the number of reflux is higher
Okay.
than no, and probably I would see if they are postprandial as well, because maybe this is not a reflux but something else, if I understand the question.
Yeah, well, it could be that you have like 200 reflux episodes per 24 hours, and they're all non-acidic, or not, maybe not all of them, but the majority of them. I would very much think that that would be rumination, especially when the pattern fits with rumination, that is postprandially. It's likely not reflux disease, but it's rumination, and it's a reason to try and get rid of the rumination, which can be hard enough depending on the age of the patient. But I send my older patients to speech therapists that works very well with them. But she's specifically trained to do all reflux related stuff.
Another question, I think this is a very good question. What opinion do you have about post-pyloric nutrition in younger patients with the refractory GERD?
I think the difficulty is not so much whether you would want to treat GERD with post-pyloric feeding. If you have a gastric emptying problem, you want to treat that with post-pyloric feeding because the problem is at the pylorus. However, the distinction between gastric emptying problems and reflux disease can be difficult. So in patients where you have true acid reflux disease that is proven to be resistant to PPI, I would prefer fundoplication. But if it's something that you want to do for a period of time with a nasoduodenal or jejunal catheter, that's fine in my opinion. I think the only thing we should try to avoid is putting in a jejunostomy in these children because most of them will grow out of it.
Okay, so a last one is, what about bile reflux? Can it present like that, like this? So
that's a good question too, and we know very, very little about bile reflux. We know that there is bile in refluxate. Sometimes there was even a device called the Bilitech, which detected bile in the esophagus for a while, but it I don't think anybody uses it anymore because we don't know what the importance of bile in your reflux really is. Can it present like this? If bile comes into the stomach, it will also be able to go up if you have reflux. So the symptoms will be similar, but I don't think you have to treat it in any different way than you do with reflux disease, as long as we don't know more about it.
okay. Okay. So yeah, I had a lot more questions, but I think we have finished the time. So thank you everyone for joining. I don't know, Mara, if you want to say anything to close the session. Thank you, Michiel, for your great presentation. I think we should, yes, I think we should do a second part of this presentation with a presentation on esophageal manometry.
Sure.
Yeah.
Thank you so much, Michiel. It was a super great talk. And for the participants, don't forget to join also our next Monday webinar. We are going to talk about liver transplant. Okay. Thank you so much, everyone.
Thank you, everyone. Thank you, Michiel.
Bye.
Thank you. Bye-bye.